What's up, everybody? My name is Max Feinstein and I'm an anesthesia resident at the Mount Sinai Hospital in New York City. In this video, I'm going to be taking an in-depth look at how anesthesiologists know that a patient is anesthetized for surgery. This is probably one of the most important things that patients think about as they're getting ready to undergo general anesthesia. If you find this video interesting or helpful, I'd really appreciate it if you liked it and subscribe to the channel. Let's dive in. Before I get too far talking about the specifics of how I know a patient is well anesthetized for surgery, let me paint a picture for you that's going to be a very familiar scenario to any anesthesiologist who's watching this. It starts at the beginning of the day when I go to the OR pharmacy and I get a lot of propofol. I mean enough propofol to keep a patient asleep for a week if I need to. Once I've got all my medications, I'll go say hello to the patient, get my operating room all set up, and then I'll have the patient come back to the operating room, connect all my monitors, induce general anesthesia, intubate the patient so that I can make sure that I can support their respiratory mechanics throughout the duration of surgery. And then once I know the patient is well anesthetized, I'll let the surgeon know you're good to start. Hey bro, can I start operating? Let's get this show on the road. Hey, can you turn on my music, please? At that point, the surgeon goes ahead and makes their first cut. And they're gonna go ahead and start cutting and whatever surgeons do to get down to whatever they need to surgerize. And everything's going super well, no issues whatsoever. Patient's hemodynamically stable, no issues with heart rate, no issues with blood pressure, there's not a lot of blood loss, everything is going fine. Then, out of the corner of his eye, Dr. Cutsalot happens to notice that the patient's pinky involuntarily moved about 2 millimeters, after which point I'll hear that favorite phrase of mine, "Oh my God, Feinstein, patient's waking up, they're awake!" Wait a second, you're telling me that after I've spent the last hour pouring propofol into this patient's veins, I mean really just letting it rip, you're telling me that the patient is now waking up? Hold on a second. Let me investigate that claim real quick. Whoa, sir, is that true? Are you waking up? Hello? I was told that you're waking up. All of my monitors indicate that you're deeply anesthetized under general anesthesia, but I was told that you're waking up. And to be honest, I was getting a little lonely back here. I don't have anybody to talk to behind the blue drapes, and I thought if you were indeed waking up, maybe I could have somebody to talk to, but it just appears that you are completely unconscious under general anesthesia anyways, so I guess I'll just continue to be lonely back here. In order for the patient and surgeon to understand what they can expect from anesthetic depth, it's important for us to review what are the different levels of anesthesia. It's tempting to just think about anesthesia as being one on-off switch where the patient's either awake or asleep, not moving, not making any memories. In reality, the different levels of anesthesia constitute a continuum, and where I want my patient to be on that continuum is really going to be dependent on what procedure is happening, how healthy is that patient, how healthy is it for me to give deep anesthesia to that patient, and depending on the circumstances, the patient's input is also going to help me determine what level of anesthesia is going to be appropriate for this procedure. So, let's start at the very lightest level of anesthesia. Technically speaking, the lightest level of anesthesia that exists is called minimal sedation. And a patient who's minimally sedated is going to be responsive to verbal stimulus, meaning I can talk to the patient and they're going to respond to me. One example where I might do minimal sedation for a patient is in the interventional radiology suite if there's going to be a procedure that is not uncomfortable for the patient, or at least the discomfort can be minimized with local anesthesia that's injected by the interventional radiologist. And it's also important in this case for the interventional radiologist to be able to speak with the patient to be able to assess their mental status. That's a case where I might do minimal sedation. In a situation like that, I see my role partly as being providing the minimal sedation, but additionally as being there for backup in case something really bad happens and we need to convert to general anesthesia. I'll be ready to do that. We'll get to general anesthesia in just a second. The next official level of anesthesia is called moderate sedation, which is defined by a patient being purposefully responsive to verbal or tactile stimulation. What does that mean? That means that if I asked a patient to do something, they might not necessarily do it, but they might move their eyes, move their hand, or if I pinch the patient very lightly on their shoulder, they might withdraw their shoulder a little bit, but they're not necessarily going to be interactive like somebody who's lucid and non-anesthetized. In case you're wondering where conscious sedation fits in, that's the lay term for moderate sedation. This is the term that you commonly hear associated with colonoscopies, where patients are awake, they're kind of alert, they're pretty comfortable, and most importantly, they're probably not making any new memories. Moving right along, the next level of anesthesia is called deep sedation, which is defined as a patient who is responsive to repeated or painful stimulus. Essentially, you really need to bother somebody who's deeply sedated in order to get them to move at all. And when they move, it's probably just going to be withdrawing from the painful stimulus, not actually interacting in a way that reminds you of somebody who isn't anesthetized. The final and deepest level of anesthesia is what we actually most commonly associate with anesthesia, which is general anesthesia. And what that means by definition is a patient who is not arousable to painful stimulus. And this makes sense because surgery typically is painful and we don't want a patient to be moving at all during surgery. And so if they're so deeply anesthetized that they're not moving, then great surgical conditions. To be a little more nuanced in my definition of general anesthesia, I typically like to think of the 4-ish A's. And those are areflexia, meaning a patient's not moving, or a patient who's minimally moving. A for analgesia, which is a fancy way of saying pain control. A for amnesia, which means not making any new memories. And if you slur your words a little bit, unconsciousness. So a patient who's unconscious. There are a couple points here that I want to touch on because they're really important both for surgeons and also for the patients. The first point is areflexia. So patients aren't always technically paralyzed for surgeries. It really depends on what kind of surgery is going on and whether there's a need to use paralytics. So in cases where we're not using paralytics, it is possible that a patient is going to have some involuntary movements that might be responses to painful stimulus, or they just might be involuntary movements that happen occasionally and it doesn't interfere with surgery, and it absolutely does not mean that a patient is awake, aware, or making any new memories or feeling anything that's going on. The other A that I want to focus on is the one that patients tend to care the most about, which is amnesia. Most patients want to make sure that they are not going to remember a single thing that has happened. And fortunately for patients, almost all of the drugs that are commonly used for every aspect of anesthesia induce amnesia, meaning most of the drugs that I'm giving, be it for general anesthesia, light sedation, moderate sedation, deep sedation, the drugs that I'm using are going to cause people not to remember anything that's going on. I think it's really important that anesthesiologists set expectations with their patients depending on what kind of anesthesia they're getting. If a patient's getting general anesthesia, then of course the expectation is going to be that they are not going to remember a single thing. But if a patient's going in for mild sedation or moderate sedation, I think it's important that the anesthesiologist set the expectation that they may be aware of a little bit of what's going on, but it's also important for the anesthesiologist to set the expectation that their discomfort is going to be minimized, because after all, that's a big part of what our job is. Now that we've covered the different levels of anesthesia, I think you're probably starting to get the sense that movement does not mean that a patient is awake. So let me just go over a few common scenarios that bystanders might interpret movement to mean that the patient is awake. And by bystanders, I mean nurses, techs, surgeons, or proceduralists who are in the room with us. One circumstance is if there's a particularly painful stimulus, it may cause a patient who's under general anesthesia to involuntarily move a small amount. And that's something that for a bystander might be terrifying and cause them to say, "The patient's awake!" But in reality, they are completely sedated, they are otherwise barely moving, they are definitely not making new memories, and their pain is fairly well controlled. And I say fairly well controlled because movement is typically an indicator for me that I need to increase either my anesthetic depth or more likely, I need to administer some medications that help with pain control. Notably, propofol does not actually have any pain control properties, which is why we commonly use other sorts of anesthetic agents to help with pain control while we're administering propofol. There are many examples of medications that anesthesiologists use to control pain, and the ones that I use most commonly include fentanyl, remifentanil, hydromorphone, Tylenol, Toradol, and there are a lot of other options. My selection of medication that I'll use for pain control is really dependent upon how long is the procedure, how painful is the procedure, how quickly do I need to make sure that I can titrate on or off my pain medication so that I can have my patient awake and alert if the surgeon needs to interact with them after the surgery. There are a lot of other considerations that go into what I'm going to be using for pain control, but suffice it to say that when I'm giving a medication like propofol, I'm also going to supplement that for the most part with analgesics that are going to help with pain. Another stimulus that can commonly cause a patient to move, or at least move just a little bit, enough for the surgeon to notice, is my ventilator. Because my ventilator is driving this mixture of oxygen and anesthetic gas and air into the patient's lungs and pressing up against their diaphragm, and depending on my ventilator settings, is actually doing that with a fair amount of force. And that can cause the diaphragm to contract just a little bit in a way that's going to make the patient appear to be moving. I just want to highlight here that the diaphragm contracting a little bit is not inconsistent with general anesthesia. And like I said, we don't always use paralytics, so it's possible that the diaphragm is not paralyzed and might respond to the air that I'm driving into the patient's lungs. This specific circumstance can be particularly annoying for surgeons who are doing laparoscopic surgery, meaning they've insufflated the patient's abdomen and they're operating inside the patient's belly using a camera, and they're right next to the diaphragm. So if the diaphragm contracts, it can distort their view, and then also if there is tightness of some of the abdominal muscles, it can make it a lot more difficult for the surgeon to manipulate their surgical instrument. So it's important for there to be communication between the anesthesiologist and the surgeon to make sure that the surgical conditions are appropriate for the case that needs to be done. Another situation that triggers people to tell me that the patient is waking up is when my paralytic is wearing off just a little bit. And paralytics, like anesthesia more broadly, operate more on a continuum, where a patient might be deeply paralyzed or somewhat paralyzed or just a little bit paralyzed. All of the paralytics that I use last for a finite amount of time, and so as they start to wear off, I need to redose them. And if I don't redose them appropriately, then the surgeon is going to notice that the patient might have a little bit of movement of their diaphragm, or their muscles might be tightening up a little bit. Sometimes this is the trigger that makes people say, "Hey Feinstein, patient's awake," when in reality, they're just a little bit light on their paralytic, but they are definitely under general anesthesia. If you ask my opinion about when a patient is actually awake, I would say, generally speaking, it's not until the patient's in the recovery room when they're awake, alert, and most importantly, making new memories. It is often the case that after surgery has ended and I have woken up the patient, they are out of general anesthesia, and we're still in the operating room, and I've removed the breathing tube, patient's talking with me, they're interactive, they're not going to remember anything. Infrequently, some patients will remember the time period right after they woke up from surgery. But by and large, patients aren't even going to start making new memories until they're back in the recovery room. So going back to the question of what does it mean to be awake, I would say an important part of that is also making new memories. And if most patients aren't making new memories until they get back into the recovery room, I would say, generally speaking, my patients aren't really awake until after surgery is over, we've left the operating room, and they're sitting in the recovery room. Not only has that been the experience that I've heard from patients who have received general anesthesia, but that also tends to be the experience that I hear from patients who have received deep sedation and moderate sedation. Sometimes patients who've received minimal sedation will remember aspects of the experience, but even those patients don't remember a whole lot of the experience. And now the part of the video that you actually came here for, which is how does an anesthesiologist know that a patient is truly under general anesthesia? There's no magic formula for this, but you have to think critically and use a lot of context. So the first part of the context is, have I administered an appropriate level of medication to this patient based on their age, based on their medical comorbidities, based on their weight, and taking these things into consideration, I can be reasonably sure, just based on the amount of either anesthetic gas and or intravenous anesthesia that I've administered, that the patient is under general anesthesia. As far as those characteristics that I just mentioned, generally speaking, patients who are older are going to require less anesthesia. Patients who are sicker are also going to require less anesthesia. And patients who weigh less are also going to require less anesthesia, because many of the medications that we use, especially the intravenous medications, are weight-based dosing. Another piece of context that I'm going to keep in mind is the amount of areflexia that I'm observing in a patient. And of course, this is going to depend on whether or not I've administered a paralytic, because if I have administered a paralytic, then a patient not moving is not going to be an indicator that I have induced general anesthesia. It just means that I have given a paralytic. But if I have not given a paralytic and the patient is not moving in response to surgical stimulus, then I can be pretty sure that they are under general anesthesia. Other really important context clues include a patient's vital signs, particularly heart rate and blood pressure. An elevated blood pressure and/or an elevated heart rate might indicate that a patient is too light with anesthesia. It might also indicate a lot of other things. Hemodynamic instability can be due to a range of surgical pathology, medical pathology, other issues that come up. But one of the things that I must consider if a heart rate is going up or if blood pressure is going up is whether I'm too light on my anesthesia. So if the heart rate's not elevated and neither is the blood pressure, then these are additional pieces of data that help me be reassured that the patient is appropriately under general anesthesia. In fact, when vital signs are stable for long enough and everything's going really well in surgery and there aren't any perturbations of heart rate or blood pressure or any of the other parameters that we're monitoring, then the graph that's produced of all of the vital signs kind of looks like train tracks. So for that reason, we can say when a surgery's been going on for a long time without any hemodynamic changes, we've got train tracks. Now, depending on what type of anesthesia that I've used, I've got some additional pieces of information that I can use to assess the level of anesthetic depth. If I'm using a volatile gas for anesthesia, so commonly that'd be isoflurane, sevoflurane, and sometimes desflurane, and in a lot of other countries, but not so much in the United States anymore, is a gas called halothane. So if I'm using any of these gases, then not only can I see the amount of gas that a patient's inhaling, which is based on what I have set on my ventilator, but I can also see the amount of gas that the patient is exhaling. And based on the amount of anesthetic gas that a patient is exhaling, I can be very confident about the amount of gas that has gone from my ventilator to the patient's lungs, into their bloodstream, and then into their brain and spinal cord, producing anesthesia. So if you go back over to my ventilator, for example, you can see that the inspired amount of isoflurane in this case is 1.1%, and the end-tidal, or the expired amount of isoflurane, is 1.0. And I know, based on studies that have been done, that this amount of anesthetic gas is more than sufficient to produce general anesthesia. There's another piece of monitoring equipment called bispectral index monitoring, which is useful for assessing the depth of anesthesia when we're using IV anesthesia, meaning we can't assess the amount of gas that the patient is exhaling. And so bispectral index monitoring is debatably useful. There are some studies that call into question how well the reading of this machine corresponds with the depth of anesthesia, but for the most part, this is widely accepted as a fairly accurate monitor, at least accurate enough that a lot of anesthesiologists do opt to use it during cases where they're giving total IV anesthesia. Essentially, a bispectral index monitor is a modified electroencephalogram, or EEG, and it calculates a number that goes from 0 to 100, and that number that's calculated is indicative of how deeply anesthetized a patient is. For general anesthesia, the target number that we shoot for is between 40 and 60. And in my experience, if a patient's bispectral index or BIS monitor is reading in the mid to high 80s, then they're probably pretty close to waking up if they haven't already started to wake up. That certainly doesn't mean that they're remembering anything that's going on, but they're starting to have more purposeful movement, and that's a number that I associate with a patient who's just about ready to be extubated at the end of a surgery where they were intubated. Then on the other end of the spectrum, if your BIS monitor reads 0 or close to 0, that says that there's not much brain activity that's going on, which might be a result of having given too much anesthesia. Since I conveniently happen to have a BIS monitor right here, let me show you how it works. And before I go ahead and use this BIS monitor, I do want to give a shout out to the Mount Sinai Department of Anesthesiology for giving me permission to use this piece of monitoring equipment, because the monitor that I'm about to put on is not free. So thank you very much to Dr. Levine at Mount Sinai Anesthesia for letting me use this piece of equipment. The first thing that I'm going to do before I put on this monitor is use an alcohol swab to clean off my forehead where this monitor is going to go. Now that I've got my forehead all cleaned off, I'm going to go ahead and open this disposable part of the monitor, which essentially consists of 4 electrodes that are on sticky pads. This is what those electrodes look like. are labeled and include an arrow for orientation. So this arrow points down the patient's face, and you have pads number 1, 2, 4, and 3 right on the temple. And then you're supposed to press the pads in, and I can feel that there are little prickly parts on here. Okay, I think we're attached, and so now I'm going to go ahead and connect this monitor to the bispectral index monitor. And once it's attached, it's going to take a few seconds to get calibrated here. And now we wait to figure out whether or not I'm under general anesthesia. Okay, we have a reading, and as you can see, I'm not quite at 100, so in theory, I guess I'm slightly sedated. I don't know. It's been a while since I've had coffee, so maybe? Anyways, if someone were to walk in here and induce general anesthesia in me right now, this number would drop very considerably, probably into the teens, 20s, maybe 30s. And then for the duration of a surgery, would probably be in the 40s, 50s. In addition to the studies that I mentioned indicating that this equipment isn't totally accurate with assessing depth of anesthesia, it's important to consider that there are some anesthetic medications that can interfere with accurate reading of this equipment. And those include any of the anesthetic gases, as well as an IV anesthetic called ketamine. Having said all that, I typically use a BIS monitor if I'm doing total IV anesthesia. Even if it's not the most accurate thing in the world, it is another data point that helps me assess the level of anesthesia in my patient. Having gone through all of the ways that we make sure that a patient is unaware and not making new memories during surgery, it is true that extremely rarely a patient will have awareness and recall what is going on. The anesthesia textbooks that cite studies on this show that the frequency of intraoperative awareness with recall happens on the order of approximately 0.1% of the time. But the devil's in the details with this, because a lot of these studies that are done count things like remembering a voice when someone is waking up from anesthesia after the surgery is all done as awareness with recall. So you really have to look at the details of what exactly a study is defining as intraoperative awareness with recall. But rest assured that anesthesiologists are very extensively trained on how to ensure that all of the components of anesthesia are maintained during surgery. And that is a big part of the reason why I have to spend 4 years in residency training to become an anesthesiologist after having completed 4 years of medical school. If you're a medical student, I hope you found this video interesting and got a sense of some of the nuances of anesthesia and the different levels of anesthesia that exist. And if you're a patient or going to be a patient receiving general anesthesia, I hope you found this video comforting, knowing that your anesthesiologist is going to keep you very comfortably asleep and very unaware of what's going on. Thanks very much for watching. I'll see you next time.